Hello, my name is Julie Nangia, and I'm a breast oncologist from Baylor College of Medicine in Houston, Texas.
Hi, I'm Komal Jhaveri. I'm a breast medical oncologist from Memorial Sloan Kettering Cancer Center, New York.
And today we're going to talk about ER-positive metastatic breast cancer. And we thought it'd be interesting to talk to you in a very practical way because there's been so many new FDA approvals this year. So we'll start with elacestrant, which was approved in January of this year. Do you want to talk a little bit about the EMERALD trial and how this is being used?
Yeah, so this has been a very exciting year for ER-positive breast cancer, and really all our efforts in the past decades of trying to understand mechanisms of resistance and to overcome them have come to fruition in some ways. So the phase 3 EMERALD trial really evaluated a new generation of oral SERDs, and in this case it was elacestrant, and we compared that with physician choice of endocrine therapy. So these were patients who had not received more than 2 lines of endocrine therapy, no more than 1 line of chemotherapy, and they were randomized to receiving elacestrant versus physician choice endocrine therapy for dual primary endpoints of progression-free survival in the intent to treat patient population and also in the ESR1 mutated patient population. And what we really found was while there was some statistical significant benefit to elacestrant even in all comers, majority of the benefit was derived in the ESR1 mutated patient population, and as such, this is where the label for elacestrant and approval for elacestrant currently is. So this is for patients who progressed on a CDK4/6 inhibitor in the metastatic setting, who've had no more than 1 line of chemo, no more than 2 lines of endocrine therapy, and have received elacestrant. And what interesting analysis was also presented by Virginia Kaklamani actually at the last San Antonio meeting was that when we looked at patients with a duration of CDK4/6 in the first line of longer than 12 to 18 months, those patients, along with ESR1 mutation, had the deepest or the most benefit. And that benefit with single agent elacestrant was in the order of about 8.6 months, which is very impressive for a post-CDK4/6 inhibitor progression patient population here. So I think this is exciting results.
Yeah, and about 40% of this population will have these ESR1 mutations. And I'll say my patients who qualify have been very happy because it's the first oral SERD that we've really been able to use in this population.
That's absolutely correct. I think, the biggest advantage of having this next generation of oral SERDs has been how can we overcome the limitations of the current approved agents, may it be toxicity, may it be mechanisms of resistance, may it be the dose-dependent efficacy issues we've had, and oral bioavailability issues we've had with fulvestrant. And so I think this has been very exciting to see that we're now making, a positive impact in that regard. And now we have patients who can get an option of taking an oral medication rather than 2 intramuscular injections in the buttocks.
Yeah. So the other exciting drug that was just approved on November 16th was Capvasb. If you want to talk a little bit about that.
Yeah, that is the newest kid on the block when it comes to targeting the PI3K AKT mTOR pathway. So we know AKT is a central node of this pathway. We know that the pathway can be activated by multiple mutations, including in the PIK3CA gene itself. We can have activation through mutations in AKT1 or even PTEN loss of function mutations can activate the pathway. And we know that these mutations can cause resistance to endocrine therapy. AKT mutations can be acquired even after CDK4/6 inhibitor therapy. And nearly about 40 to 50% of the patient population can really have alterations in 1 or more genes. So the Capitello 291 study, the phase 3 trial that evaluated this AKT inhibitor, this is an AKT inhibitor of all 3 AKT isoforms, AKTs 1 through 3, combined with fulvestrant. And when we looked at the dual primary endpoints of progression-free survival for all comers and AKT-altered pathway, we did see a statistically significant improvement of progression-free survival that improved from nearly 3 months to about 7.3 months, favoring the Capvasb with fulvestrant arm. And this patient population was about 70% that had received prior CDK4/6 inhibitor, 20% who had received prior chemotherapy. But again, the benefit was probably predominantly seen in the AKT altered pathway, in that the hazard ratio in the AKT altered pathway was 0.5. About 44% of these patients were identified to have alterations in 1 or more genes of PIK3CA, AKT1, or PTEN. And this was 44% on the clinical trial. 16% were still unknown with respect to the alteration status. And so when we looked at the exploratory analysis of the non-altered patient population and excluded the 16% unknown, the hazard ratio there was 0.8. perhaps suggesting that maybe the benefit is coming in more from the altered patient pathway. And as such, that is where the FDA approval is, where these would be patients who have had any one alteration in the PI3K, AKT1, or PTEN pathway, have had potentially a first-line therapy, predominantly with a CDK4/6 inhibitor, that can be then offered capivasertib with fulvestrant. And maybe a word about a toxicity profile here. The most common toxicities that we see with capivasertib is really diarrhea and rash. Grade 3 diarrhea was about 10% of our patients, and then grade 3 rash was about 17% in the PI3K, AKT1, PTEN altered patient population. None of these patients had any primary prophylaxis offered on the clinical trial, so hopefully when we start utilizing the drugs and start using prophylaxis for rash, as we've been doing with other agents of this pathway, including alpelisib, hopefully we can control this rash a little better for our patients.
Okay, and I guess to end with, are there any other new exciting drugs up and coming in this metastatic breast cancer field that you want to mention?
Yeah, there has been a lot of effort in this space. There are multiple novel endocrine agents. We have multiple CERANs and PROTAC. CERANs as complete estrogen receptor antagonists. We have palazestrant in that regard. We have PROTACs such as the vepdegestrant molecule or the ARV-471 molecule. We have lasofoxifene, a novel SERM. We have newer cell cycle inhibitors that are entering clinic, CDK2s and CDK4 inhibitors. And on Friday at the San Antonio meeting, we'll be presenting for the very first time data for triplet strategy of a PI3K inhibitor, inavolisib, with fulvestrant and palbociclib versus placebo fulvestrant palbociclib for patients who are endocrine resistant, i.e. they have recurred on or within 12 months of their adjuvant endocrine therapy and have a PIK3 mutation, are treatment naive. So we're looking forward to seeing those results, which based on the press release seem to be very positive for the primary endpoint of PFS.
Okay, thank you for interviewing today, and this just gives us a lot of hope for new treatments that aren't chemotherapy.
Thank you so much.